would let me see if there are any other topics to discuss. Okay, so there's also disease of the upper respiratory tract and then respiratory failure. Those are short topics, so would briefly go through that the next time we meet in class. So hopefully this weekend. So today we'll talk about pulmonary edema, and we've been doing a lot of pulmonary edema recently because of cardio, and we did a lot of discussion on heart failure and all that. And we said once the heart fails, one complication we can see is we can get from that is pulmonary edema. Now we've moved to the respiratory system itself, so it's prudent we just talk about pulmonary edema again, and then apart from heart failure, I'll look at the other common causes of pulmonary edema, because you could also have pulmonary edema developing from other conditions other than heart failure. So the focus and then we'll look at how it comes about, and the presentation and how we manage the various types of pulmonary edema. So we know that once you're talking about edema, then it means there's an accumulation of fluid somewhere. So the same would go for pulmonary edema. Basically, you have accumulation of fluid in the lungs, as the name suggests, pulmonary. So you have accumulation of fluids in the lungs. And we know that in the lungs, you're not supposed to have accumulation of fluids. What you're supposed to have in the lung is air, okay, instead of fluids. So when you have accumulation of fluids in the lung, then you tend to compromise the functional activity of the lung. In pulmonary edema, there's a lot of fluid accumulation there in the lung, and this is because of basically changes that the blood vessels in the lung undergo. Okay, so what is happening here is you have accumulation of fluid in the lung, and it's a secondary to extravasation of fluid. Once we say extravasation, then we say movement of fluid or leaking or seeping of fluid from one side to the other. So the fluid accumulation in the lung is secondary to seeping of fluid from the pulmonary vessels into the interstitium and then the alveoli. Okay, and that is what will lead to the edema. Ideally, we expect that the fluid in this case, which is the blood, will stay in the blood vessels of the lung. But once certain changes occur, certain changes in either the blood vessel or certain changes in the blood vessel or the blood there or pressures in the blood vessels, once you've got certain changes in the pressures of the pulmonary blood vessels, what happens is that there's some sort of seeping or leakage of fluid from the pulmonary blood vessels into the outer aspect, what we call the interstitium. And once this happens, we say you've developed an edema. Okay. So as we go on, we'll get to understand the pathophysiology and it would make more sense. But just know that it's just accumulation of fluid in the lung, which is secondary to extravasation of fluid from your pulmonary vessels, okay, into the interstitium and the alveoli. Okay. So when you look at the pathophysiology, this tells us how the extravasation of fluids come about. What is going to happen is when you look at the first point, which we say imbalance of Starling's forces. Once you're talking about Starling's forces, you're talking about pressures in the blood vessel. Okay, so with Starling's force, we say that once pressure increases in the blood vessel, or what we term as increased hydrostatic pressure, once you have an increase in pressure in the blood vessel, it causes you to push fluid out to the interstitium, okay, or extravascular compartment. So increased pulmonary capillary pressure is going to cause a seepage or extravasation of fluid into the extravascular compartment. And once you have seepage of fluid into the extravascular compartment, an edema will develop, okay, and in this case, pulmonary edema. So that's one. The other aspect too is oncotic pressure, and oncotic pressure is usually based on your albumin level, okay, as a person. Once your albumin and your protein levels are dropping, your oncotic pressure would also drop. And once your oncotic pressure drops, then you are at risk of leaking fluid from intravascular compartment to the extravascular compartment, which will lead to an edema. So a classic example is when we see kids who are malnourished, who have kwashiorkor. Okay, so protein deficiency, one of the striking features is that they tend to have some form of edema, their tummy, their legs look swollen and all that. This is because they lack proteins. Their albumin levels have gone down, and as soon as your albumin levels go down, oncotic pressure will decrease. And when oncotic pressure decreases, a complication in this situation is leaking of fluid from the intravascular compartment or from the blood vessel to the outside, which is extravascular compartment. Okay, so the other aspect of Starling's forces is a decreased plasma oncotic pressure. Okay, the third one, there's an increased negative interstitial pressure. What this means is that basically you want a balance. You don't want to have too much pressure somewhere. You don't want to have too less pressure somewhere. Okay, so in your body, you always need a balance so that they will be in homeostasis. So when you go to the interstitial compartment, we need to have a sort of balance, same as what is happening in your intravascular compartment. But when the negative pressure there is greater, then once you have negative pressure, what is happening is you are going to try and suck in fluid from the other compartment to change that increased negative pressure that you have. You'd want to sort that negative pressure out, and in sorting the negative pressure out, you tend to suck fluid from the intravascular compartment to the aspect where you have the negative pressure so that you can have a balance. And in so doing, you end up developing some form of edema. Okay, basically that's the Starling's forces. The other aspect of pathophysiology we can look at is whenever you have damage of any structure, the structure basically becomes leaky, and once it becomes leaky, you have fluid crossing the borders easily into the extravascular compartment. So for instance, if the alveoli becomes damaged, then it becomes leaky, and then things can actually move through the alveoli capillary barrier to the other aspect, and then you have an edema forming. Okay, so that's also one of the ways you can develop an edema. If you have the lymphatics becoming obstructed, let's move away from the lung a bit. You have a patient who has a swollen leg, edema, and then we check and we say that, oh, this patient, it's because the lymphatics have become obstructed. You know, the lymphatics are also like vessels that carry lymph, okay? And what happens is that this lymphatics, they don't really have a middle muscular layer like the way your arteries have to be able to pump the lymph upwards and all that. So they rely on the action of what we call valves, just like the way your veins in the legs rely on valves. So whenever they become damaged a bit, then we are going to have the lymph staying in that area for a very long time. It becomes dependent, and hence it starts leaking into the extracellular compartment. Edema. The same thing can happen in the lungs. You have lymphatic vessels everywhere in the body. So if your lymphatic vessels in the lung would basically undergo stasis, and once it undergoes stasis, it will start moving out of the lymphatic space, and then you have an edema developing. Okay, basically that's the pathophysiology. If you have any question on this part, you can put it forward. We go through and then we continue. The two main words are, we are looking at intravascular space and extravascular space. The focus is on keeping a balance between the intravascular space and the extravascular space. Anything that affects the balance will cause movement of fluid from the intravascular space to the extravascular space. And this movement of fluid from the intra to the extra is what will lead towards the edema. Okay, so any questions, please? All right, so
hello, Doc. Please,
yes, Mabel.
Of fluid, is it in the form of osmosis or what?
Okay, okay. So should we say it's in the form of osmosis? Because, well, yes, osmosis is through a semi-permeable membrane. So maybe you can use that mechanism to understand it well, because in this case, your blood vessel becomes leaky and then it sort of forms some sort of semi-permeable membrane. So if we remember osmosis carefully, in osmosis, we are saying it's moving from a region of a lower concentration rather to a higher through a semi-permeable membrane, right? That's osmosis, and diffusion is higher to lower. So that is, so that is where the difficulty will come in, because it doesn't really do that by osmosis. It's just leaking out. Because if it's osmosis, then you expect that it will move from a region of a lower concentration to a region of a higher concentration. But in this case, the movement is rather based on forces, what we call Starling's forces. And that is not classic osmosis. You get it?
Okay.
If you take something like the increased hydrostatic pressure or the increased capillary pressure, what is enabling the thing to move through the blood vessel to the extravascular space is the fact that the pressure in the intravascular space has gone up, and that is what is enabling it to move. So when you use osmosis in that sense, it will defeat the purpose, because osmosis is supposed to be from a region of a lower concentration to a region of a higher concentration.
Okay.
Yes, please.
Thank you very much.
You're welcome.
So I'm also thinking that just as how a movement of substances from the lipid bilayer of the cells happen, that I think that is somehow. Yeah.
Yes. You can use that. That also makes sense. So, I mean, once you are crossing cells, because moving from the inside of the blood vessel, you are basically crossing cells. So, yes, that also makes sense. Okay. So when we go to the staging of pulmonary edema, you could have a pulmonary edema which is very mild and it's not really giving you symptoms of difficulty in breathing. Okay, so that one, it's like the initial phases of pulmonary edema. The pulmonary edema is now starting. So basically the blood vessels have become engorged just a little bit. And then you can have a moderate pulmonary edema. So in this case, blood vessel has become engorged, and now you have the whole leaking process or extravasation process going on. Okay, so it's moving from the pulmonary vessels into the interstitial state. And then the last stage, you say severe. So this is when the alveoli becomes involved. And you know that the alveoli is a very vital area, because that's where oxygen diffuses into the system, carbon dioxide diffuses out of the system. So in a severe case of pulmonary edema, there's alveolar edema, the whole alveolar capillaries becomes edematous. And so gaseous exchange at this point is impaired, and this patient will come to you very, very, very breathless. Okay, so once you are moving from moderate to severe, it means alveolar involvement is beginning to develop. Once alveolar involvement comes in, then you know that you've got into severe. Okay. So I said there are two main parts. You have the pulmonary edema that will develop from the heart. So as a complication of a heart failure, you can have a pulmonary edema, and then you have pulmonary edema that will develop from other things, which we'll be talking about as well. Okay, so someone can have, can undergo some form of trauma to the nervous system, and then as a reaction to the trauma, you develop a pulmonary edema. Okay, someone can climb to a very high altitude and all of a sudden starts feeling breathless, and then the person develops a pulmonary edema. So we'll go through that as well. So let's touch on the cardiogenic again, because it's one of the commonest areas where people tend to develop a pulmonary edema. Pulmonary edema with neurogenic and all that is not so common in clinical practice, even though it can happen. The ones we tend to see is the pulmonary edema, which is secondary to the failure of the heart. And with this, we've talked about it in class, but we'll go through all over again. So what is happening here is you've got edema developing in the lungs because the pressure in the pulmonary vessels have gone high. Okay, basically that's why the edema is developing. So the question is, how has the pressure in the pulmonary veins and all that gone high? And that is where the heart failure comes in. And you remember we said you take the heart, you have your right side and then the left side. Ideally, blood gets in through your vena cava and all that, gets to your right atrium. Then from the right atrium, it has to go through the tricuspid valve, gets to your right ventricle, then it shoots up through the pulmonary artery, goes into the lungs for oxygenation, and then returns through the pulmonary vein to the left atrium. From left atrium, it goes through your mitral valve, and then from the mitral valve, it enters your left ventricle, and then the left ventricle will then shoot it up again, goes through up, and then it comes out from your aortic valve and then goes into systemic circulation. Ideally, that's how the movement goes. But when the heart is failing, and you are looking at a left-sided failure in this case, blood returning to the heart through the pulmonary vein, okay, gets there, enters the left side of the heart. The oxygenated blood would get to the left side of the heart. But once it gets to the left side of the heart, we expect that ideally the left side of the heart to be able to contract and push this blood into systemic circulation. But because the left side of the heart is failing or has failed, it keeps getting filled with blood and is unable to fully pump the blood out. Like blood comes in, and ideally, you remember we said when blood comes in, it should stretch the ventricles and it should create a recall for the ventricles to contract and push the blood out. Blood comes in, there's a stretch, but this stretch is not a full stretch because the left side of the heart has basically failed. So blood comes in, we are unable to pump, the left side of the heart keeps getting filled, and eventually the blood will backtrack, or there'll be a backflow of blood into the pulmonary vessels. And once you've got a backflow of blood into the pulmonary vessels, then we've got a problem, because we expect that the blood rather move from the pulmonary veins and come to the left side of the heart. But in this case, there's now a backflow going back into the pulmonary veins. So this is going to build some sort of pressure in the pulmonary veins over there. And once the pressure builds up, you're going to have an increased hydrostatic pressure there, which we said is part of the pathophysiological processes for edema to form. So once this happens, then you are going to have the pulmonary vessels becoming leaky, fluid pumps to the extravascular compartment, and then you have your edema developing. Okay, so that's how heart failure will lead to pulmonary edema. Once this happens, with time, it becomes progressive. You get to the severe stage, or stage 3, where alveolar becomes involved, as we've looked at, and then this will mean that gaseous exchange will be impaired, and hence there'll be difficulty in breathing there as well. So what are the common causes of heart cardiogenic pulmonary edema? You have left ventricular failure, which we've talked about. So the left ventricle has failed, basically because of maybe a complication like severe hypertension, or maybe the patient has the mitral valve destroyed, or any component of the left side of the heart's becoming destroyed. So there's basically backflow of blood, which backtracks into your pulmonary veins, and then there's a pressure buildup. So left ventricular failure, left outflow obstruction, okay? Anything that will obstruct blood from moving from the left into the systemic circulation would cause the heart to become congested with blood, and hence there'll be backflow into your pulmonary vasculature. When you have a patient who you think needs IV fluids and then you overload your patient, you would sort of flood the patient through your IV fluid administration. So you are giving a lot. The heart is failing, is unable to pump, and hence the heart becomes congested because you are increasing the preload. You've increased the preload. You have a lot of fluid getting into the heart, but then the heart is unable to pump all the fluid out. So it would have to find somewhere to go. And in this case, it gets into the lungs because you are looking at the left side. And once that happens, you'd have some form of edema developing. Okay.
So,
and then of course, yes, please.
oh, sorry, you are in the middle of a statement. You finished it now.
Oh, no, that's fine. If you can come.
Yeah, with the excessive intravascular administration. So does
Yeah.
it mean if somebody is suffering from hypotension, maybe the blood is not able, the heart is not able to pump well or like contract well? There's no need to give IV.
All right. Okay. Okay. So if you say hypotension, there are different causes of hypotension. The question is, what is causing the hypotension? If you have a patient who has hypotension, you want to say that the blood pressure is below 90/60, right? So yes, below 90/60, your focus now is to look for the cause of the hypotension. We don't manage all hypotensions with quickly going to give IV fluids. If the hypotension is due to hypovolemia, so you have a patient whose fluid volumes have dropped drastically through vomiting, through diarrhea, or patient has been involved in an RTA and is bleeding and all that, that will also cause hypotension because you are losing fluid or you are losing blood one way or the other. So your BP would drop. So this kind of hypotension is secondary to what hypovolemia. And that is what we say the patient has what hypovolemic shock. In managing this patient, you have to give IV fluids as part of your resuscitation because the patient is losing fluid. So you quickly have to go resuscitate and then replace the volume that the patient is losing. So it is imperative or it lies on you to give fluids. However, if you have hypotension, which is secondary to the heart failing, so maybe you have a patient who has a myocardial infarction, and because of the myocardial infarction, part of the myocardium has ruptured. Let's say the left side of the ventricle, which is supposed to be thickened, or has ruptured. Once it ruptures, the heart is unable to pump, so the heart will fail. So once the heart fails, the heart is unable to pump fully to push blood into circulation for you to maintain your usual blood pressures, right? So what's going to happen in this case is that your left ventricle has ruptured, heart is unable to contract fully to push blood into circulation, BPs are dropping. This would also lead to hypotension.
Yeah.
But in this case, you don't want to go and give your patient IV fluid. Why? Because unlike the first case where the heart is actively working, which when you give your IV fluids, the heart to be able to act as a pump and pump the fluid into circulation for you to have a good BP. In this case, the heart is failing. So when you go and give the patient IV fluids, you are actually making the job of the heart difficult because the heart has ruptured, is failing. It will be unable to contract fully to push the blood into circulation. So giving this patient IV fluid will rather cause congestion in the heart, and then a further congestion in the pulmonary vasculature and a pulmonary edema.
Okay. Okay.
Are you okay? Yes. Yeah. So in that case, so yes, please.
So what do you have to do? You have to wait for your investigations to come in before you know whether this is a hypertension secondary to maybe myocardial infarction or something.
Okay. Okay. So you don't always need to wait for investigations. In the olden days, they didn't have echo and things to find out to detect a rupture of a myocardium, but they were still managing their cardiogenic shocks well. In the olden days, you didn't need some form of investigations to see if this shock is from here or here. Why? Because history is very, very key. And as I say, as clinicians, our focus should always be on the history, because that is what we are starting with. Because after you've taken the history, you will have your diagnosis. You can't just go straight and examine a patient without taking a history. You get me? So yes, so the history is very, very, very important in this case. So how would you know you are dealing with a cardiogenic shock? The history will give it away. So patients will come and then tell you that, all right, okay, or whoever is bringing the patient would say, so he was fine. All of a sudden, he started having severe left-sided chest pain, which was radiating up to the neck and all that. They've given you a classic history. So you expect that when you are checking this patient's BP, ideally the BP should be high because they've given you a history of a myocardial infarction. And we said one of the main causes of myocardial infarction is what? Hypertension. When your BP goes up and all that, and then you have a blockage there, you have an acute coronary syndrome, all that will lead to an MI, myocardial infarction. So this patient comes to you and you check, and your initial BP check, the BPs were very high. All of a sudden, you haven't given any antihypertensives at all. You are managing this patient, and then the BP starts dropping gradually or starts falling, and now you realize BPs are falling very fast. Clearly, this patient is not running, doesn't have diarrhea, it's not vomiting, hasn't gotten any RTA where you can see visible bleeds and all that. So that tells you that, okay, the patient is developing hypotension, but this hypotension is not because the patient is losing fluid or all that. The history suggests left-sided chest pain, all that, something cardiac. So that tells me that, all right, this particular hypotension is not your usual hypovolemic shock that we see when your patients will come with diarrhea and vomiting. No, not at all. But this hypotension is coming from somewhere else. It's coming from the heart. So you are not in a hurry to go and give the patients lots of IV fluid. Your focus here is to give something else which would help the heart contract more, rather than giving something which would overload or overburden the heart. So the history is very key. In the same way, if a patient comes to you and tells you, I have diarrhea and vomiting, and I've been vomiting, I've gone like 20 times, stool like 10 times vomiting, and the BPs are low, cold, clammy extremities and all that, patient is very weak and lethargic, then clearly you know that this is what hypovolemic shock secondary to gastroenteritis. So you don't even have to wait for investigations and all that to say you are starting resuscitation. You quickly start giving your crystalloids, Ringer's lactate or normal saline. Okay.
Yes, sir.
All right, great. You're welcome. So I was going to talk about the pulmonary venous obstruction as well. So yes, so anything that obstructs flow. So when you go to the mitral valve, if you have a mitral valve stenosis, mitral valve is on the left side, a stenosis there, or you have a tumor sitting in your left atrium, it's actually going to obstruct blood flow. Okay, so once you have this obstructing blood flow, it means the pulmonary vein bringing in blood comes, the blood gets to the left side of the heart, all right, but is unable to get to the whole aspect of the left side of the blood, the heart, for the heart to be able to contract and push it out, because you've got some mitral stenosis. So the blood is just collected in your left atrium, and then there's a backflow or it goes back into your pulmonary vein, or you have a tumor sitting in the left atrium. So the blood gets to the left atrium, and because the tumor is obstructing, there's a backflow to your pulmonary veins, and then eventually pressure builds up in the pulmonary veins. Okay. So at this point, I'll just drop the link and then we'll all reconnect again and then try and finish up.
All right, Doc.